just need to give ourselves some pat on the back. And it's been a long journey. But I just wanted to take the opportunity to thank everyone for being here, to thank folks that are online, our guest speaker, our and members of the public and our commission members as well. My name is Dr. Oluwatosin Olateju. I'm the presiding co-chair for this month's meeting. I'm joined today by my co-chairs, Dr. Boris Kushner, Dr. Mina Brewster. The co-chairs will be assisting me with the flow of the meeting, and we also have our support staff, including Michelle Kong, Jonathan Nesford, and Shane Adjet. Additionally, we have some of our commissioners here, our work group members, academic partners that are also present, and some are joined online. We're fortunate to have an amazing guest speaker in our midst, just joining online, Dr. Deborah Thompson from One Health, who will be introduced later today. This is a hybrid public meeting, and we appreciate all that have joined us. Please note that we followed the requirements of posting a notification of the meeting online. We'll continue to provide advance notice of the information on our homepage. If you're not familiar with our website, it's https:/smchd.org/Commission on Public Health. Also, make sure you follow us on LinkedIn and stay engaged with our commission's activities. We thank our hosts, as always, the Prince George's County Health Department, for allowing us to continue to use the, to have our monthly meetings here, and also for the refreshments. Some housekeeping items to note. The commissioners are welcome to unmute their mics when they want to ask questions or share comments or participate in discussions throughout the meeting. I kindly ask that all commissioners please identify themselves before speaking during the meeting, so people in the room and those attending virtually can know who's talking. Additionally, we ask that non-commission members, if you have any questions or comments, please, if you would send them to our email, which is md.coph@maryland.gov. While we appreciate all of the comments, unfortunately, we have a tight agenda and we will not be able to take them today. All members of the public should please have your mics muted throughout the meeting to prevent background noise. Unfortunately, we'll not be doing a formal roll call for work group members, commissioners. However, you're welcome to sign in here in person or simply type your name and work group affiliation in the chat box for our records. So I'll now ask Shane, our Senior Advisory Manager from 60 Foundation, to please conduct the roll call. Thank you, Shane.
When I call your name, please respond with here or present. Delegate Bagnall. Camille Blakesball.
Present.
Christopher Brandt.
Yeah, coming forward.
Mina Brewster.
Here.
Jean Drummond.
Here.
Senator Lamb. Matt Levy. Here. Alyssa Lord. Boris Lishniak. Here. Galesh Kalyana Raman.
Present.
Wilson Olateju.
I am here.
Fran Phillips.
Here.
Laura Roston.
Present.
Nicole Rochester.
Here.
Bill Spencer.
Here.
Alan Twig.
Here.
Capricorn.
We have a call. Thank you, Shane. Oh, Senator Lamb just joined. Thank you. So next is the adoption of agenda. The meeting materials, including the agenda, were emailed and have also been posted on our commission's webpage. I would like to entertain a motion to adopt the agenda. Thank you. All right. Any discussions or questions? All right. Get online. All right. I do not see.
Quick note, Delegate Bagnall is here.
Oh, Delegate Bagnall is here. Thank you. Sorry, can I get see? Oh, thank you very much. All right. Since there are no discussions, I'm going to have to take the vote. All in favor of adopting the agenda, please say aye.
All right.
All right.
Aye.
Any nays? Okay. Thank you for those online. Any nays? All right. Nays or abstention? All right. No. Okay. Thank you. All right. The motion is approved. And the agenda has been approved. All right, we're gonna move along to the November 20 minutes review and approval. I just want to use the opportunity to say thank you so much for those that joined. We'll still go into details about the interim report, but I just want to say thank you. We have the minutes. They were also shared via email. They can find online after it's been approved. But I want to direct your attention to just take a quick glance at it. We show okay.
I don't.
Well, you have it. If there are any questions about it, but I'll take a motion, all right, to approve the November 20th special interim report meeting. Okay, Dr. Levy, thank you so much. All right, are there any discussions about the meeting that we had on November 20th? No discussions, all right. All in favor, please say aye.
Aye.
All right, are there any nays? I do not see any, so the minutes from November 20th has been adopted. Thank you so much. All righty, we're not going to move on to the next item. We have our guest presenter here, Dr. Deborah Thompson from One Health. She'll be presenting about One Health and what you can do about it today. I'd like to call on Boris to please introduce our guest speaker. The bio for our guest speaker is attached in the written materials today. You can also find it online. Thank you, Boris.
Great, thank you so much, Wilson. And it's my pleasure here to introduce Dr. Deborah Thompson. She's the author of The Art of Science Communication and the chair of the World Veterinary Association's One Health Education Subgroup. She founded an educational nonprofit organization that inspires children and adults around the world to value the interconnection between public health and the health of the environment, plants, and animals. These are called One Health lessons. She has served as a science policy advisor in the United States Congress, also a clinical veterinarian and award-winning public speaker. Her articles have been printed in multiple publications, including The Lancet Planetary Health. The Commission welcomes you, Dr. Thompson, and please share with us your wisdom about One Health. Thank you so much.
Thank you.
Well, thank you very much, everybody. It's a pleasure to be here today. I'm joining in from not too far away. I'm right now in Alexandria, Virginia, so it's a pleasure to be joining you this afternoon. Today, we will be talking about what One Health is, why we should care, how we can act upon One Health, and explore some avenues to further One Health in the future. Now, I hear a little bit of background noise. I don't know where that's coming from, but I wanted to just let everybody know that the way I give presentations, I make it very interactive. So feel free to mute yourself until you have something to shout out today, okay? So our plan today will be figuring out really what is One Health and say it simply. And if it's possible to just mute yourself, I'd appreciate it. Thank you. Number two, how does One Health actually apply itself in Maryland? When it comes to communication and public engagement, I saw that that's one of the things that the commission recommends and provides feedback on to the government at large. So I wanted to flag that. We'll touch upon the workforce and the funding, and then we'll go through some questions. Let's just see and make sure that everybody is muted. If from the room, I'm just getting a little bit of extra feedback. If it's possible to mute the meeting room. Okay, thank you. Thanks for working on that. Oh. So let's get started. What is One Health? One Health can be explained in two different ways. We're going to keep it very simple though. One Health can be described as a concept and an approach, whereas that One Health concept is just simply that interconnection between public health and the health of the environment, animals, and plants. We don't live in a bubble. Everything is connected. A sick environment can lead to sick people, sick animals can lead to sick people can lead to sick animals, and it goes round and round and round. So a lot of people say, oh, well, that's common sense. And I would say, yes, it is. But it's something that a lot of people don't talk about actively. So the One Health concept, if you want to say it in a single word, it's interconnection. And an infographic that goes along with that interconnection would be something like this, taken from a massive infographic that you might be familiar with. Now, let's just talk about the One Health approach. Put simply, in a single word, is teamwork, but more expansively, it is teamwork between people of different backgrounds, disciplines, strengths. We come together to solve and prevent health challenges. And those health challenges can affect people, the environment, animals, plants, again, because we're all interacting with each other, right? And so it brings people from all these different backgrounds, disciplines, strengths, sectors together in order to solve some mighty problems. This is the bigger image that some of you might be familiar with. It's taken from the One Health high-level expert panel that is responsible for providing some feedback and guidance to the United Nations in One Health capacities. We'll touch upon this a little bit later on. But in a nutshell, the One Health concept is that interconnection. The One Health approach is teamwork. It's as simple as that. Now, how does One Health actually apply itself in Maryland? Well, let's think about how temperatures have been changing, how the environment has been changing. This is a graph taken from the NOAA website. And as you can see that the average temperature has been rising consistently on average. So this is the interactive portion, or the first interactive portion of this talk. When you look at these images, say for instance, the top right image, you see these two men wading through some very high water. Coming from the public health perspective, in a sentence or two sentences, can you speak about what you might be most concerned with? Shane, if you see anything in the chat box, feel free to unmute and speak up because I can't see the chat box actively. Now, I challenge you even more to say that, pretend that upriver, up road, but upriver in this case, there's a farm. And this water has been in contact with that farm. Now, what are you concerned about? When I bring this image,
Water contamination.
water contamination, perfect. Thank you. Thank you. And that's exactly where the medical students go on this. And I say, well, if we're talking about a farm and we're talking about manure and we're talking about things like, you know, bacteria that could be flowing in this water, what type of cultures are you going to be running on these men if they have open sores on their feet or on their legs, right? So then we have that whole discussion about antibiotic resistance, antimicrobial resistance in general. Now, I have another question for medical students, typically with this image on the top left. Happens during a hurricane. What if the homeowners go to an emergency department, okay? And they're fortunate enough to have survived. But they come back home and there's no home left. So that's a push for having something like social workers or similar professionals in emergency departments on a regular, not just when there are disasters, but just having people of different backgrounds working in the same place at the same time in order to meet the needs of the community. Now, look at the bottom left here, a wildfire. Now, with climate change, there's more and more active wildfires. You might think, okay, well, smoke inhalation would be a major concern. Migration of people would be a major concern. What about after the wildfire gets addressed by first responders? What type of material might be in the soil? Think about the potential for erosion. You see, when there's a simple image, there's always a complicated story, not only during the time of the image being taken, but then follow up. And that's where we professionals come in. But the thing is, it's a bit traditionally, I'll say it like this, traditionally, it's been a bit naive to think that one sector can solve all the problems, right? So in the bottom left, I would say, besides, of course, the first responders, the social workers to help take care of the people who are mentally affected by this particular event, and humanitarians and nonprofits and things like that, and governments, of course. But also remember the environmental health scientists who would be involved in the recuperation of this community. Now, on the bottom right, it's not just the people in front of you. If you're a physician or a veterinarian seeing an animal in front of you with their family, it's not just the people in the room that could be affected. There could be long-standing and further consequences of these disasters. So this is where a conversation has to come in. And I have been deployed when I used to live in California with the California Veterinary Medical Reserve Corps because I'm a veterinarian. And back in 2018, there was a wildfire, a massive wildfire at Paradise in California. And there I was responsible for a whole sector of animals. And I remember meeting this one woman who was bald, and she said that she rushed back to her trailer while the flames were approaching to save her parakeets and her rabbits. Because she told me, and I quote, "I live for my animals." So with that story, a true story, how do we collectively, through all the different sectors and disciplines, come together for disaster preparedness? We must include a lot of different people. And so, like I said before, there are some unexpected conversations that might come up from just a simple snapshot in time. Now, One Health is not just about disasters. One Health is about everyday life. I noticed on the Baltimore County government website where there's, just look at these bottom three. How can that affect animals, plants, the environment, and people all at once? I think I don't need to explain exactly how, but it can be pretty obvious. Think about the chemicals in the pools, thinking about the food safety, right? So remember though, locally and in many different places around the world, temperatures have been going up and up and up. There's something else that can go up with temperature changes. You see, climate change is a threat multiplier for the spread of infectious diseases and antibiotic resistance. You probably knew I was going to be talking about antibiotic resistance sooner or later. And since we are talking about bacteria, I just want to gently remind everybody, typically it's 1 out of 5 resistant antibiotic infections are related to animals and food. But my question is, where does the rest come from? We're talking about 4 out of 5. So farmland, veterinary care, that's only a piece of the puzzle if we're trying to combat antimicrobial resistance. So wanted to just flag that for everybody. Now, when the degrees go up on the thermometer, so do the risks of things like salmonellosis. This is from a study that I referenced in the notes, and just note to the organizers that I did send a updated file recently, so that can be posted on the website. But coming from the perspective of how to speak with policymakers, I have had the great fortune of working in science policy in Congress in Washington, D.C. I was a science policy advisor, technically a AAAS fellow, policy fellow. So AAAS is the American Association for the Advancement of Science, policy fellow, and then I was hired on. And I was working in the Senate. So there I have had the experience of having people of all different science backgrounds coming into the office, speaking their piece, but oftentimes my colleagues, after the guests leave, they turn to me and they say, Deb, what does that mean for us? Right? What does that mean? Can you translate that for us? So I'm constantly translating. And so from there, I wrote a book about it. We'll talk about that later. But these are some pieces that I think are very important to realize when speaking with policymakers. So the everyday person knows salmonella can cause sickness in people, it causes recalls. And of course, when there are recalls, there's public trust that is at risk. What the policymakers really need to drive home for the policymakers is the economic impact. Okay. It's not just for the food companies, it's for the sick families. Now people can understand when there are people who are sick in the hospital, they cannot make money, just like during COVID times, right? So those types of points are really important to play up when speaking with policymakers. You can also, of course, speak about resistant strains causing more sickness in the community and longer hospital stays. But ultimately, when speaking with policymakers, there are a few things that are just very, very important to remember. If you come with problems and no solutions, it's not helpful for the policymakers and their team. And when I say team, I mean their staff. They already know that there's a slew of problems out there. What they need from the experts, you, is to offer solutions. And those solutions have to be feasible. Can it be done within a certain time period? Does it cost an arm and a leg, or is it actually reasonable? And how many people need to be involved? How does it affect their constituents, their voters? That's also very, very important for them. And then is it cost effective? They might be willing to pay an arm and a leg if you pitch it right? If you say with your constituents, they will benefit from the year 2024 onwards, and the projected improvements would be X, Y, and Z. And especially if you talk about the improvements and how much it can save on costs, that's going to be very, very helpful for them. In the book, The Art of Science Communication, Sharing Knowledge with Students, the Public, and Policymakers, there are chapters dedicated to how to speak with policymakers about certain things, especially in the public health space. This is just a zoomed in of the different chapters. And so now let's truly dive into communication and public engagement, because like I said, it looks like the commission is advising the state government on communication and public engagement, workforce funding, and a slew of other topics. So if you remember that large infographic about One Health, you can see that communication is right in the top and in the center of the entire image. But right now, because we're talking about government and mobilizing people to act at a local level, regional level, even up to a national level, we're working with several different types of communities. It is important to really pinpoint how can we communicate effectively. Now, thinking about a timely One Health topic, H5N1, here's just an example of how I would present the idea of H5N1 and trying to find solutions for policymakers with H5N1 today. So you could just state the problem and keep it very, very simple. It's a virus. It spreads from animals to people, and there's a great concern of potential for human-to-human spread. Right now, there's been a teenager found in Canada. We don't know what caused this teenager to actually get H5N1 or bird flu, but this teenager is now critically ill. And that is a major concern because Canada is not far from the United States. Historically, half of the people who get this virus die from it. Now, right now, what scientists, I'm sure you're all aware, are realizing is that the mortality rate is not as high, knock on wood, as traditionally has been seen. However, the point of this is to say, don't use jargon, right? Don't use things like mortality rate when speaking with policymakers. Just say it straight out. So that's the problem with highly pathogenic avian influenza. Here's some possible solutions that I think could be appealing for policymakers at the local level, state level, federal level, and beyond. So think about ways how a cow can spread avian influenza virus to people. If people do not pasteurize their milk and they drink raw milk, well, then they can get this virus. So create policies to stop selling raw milk. So on a federal level, I could have asked my boss, the senator, to see if she was interested in writing a letter to the FDA commissioner, or through appropriations, because my boss was on the appropriations committee in Congress, to try to move funding in order to restrict the selling of raw milk, for instance. Then another option is to increase funding for researchers to develop an all-inclusive flu vaccine. Now, traditionally, that has been exceptionally difficult because of all the different variants. But again, the whole purpose of this idea is to get an all-inclusive flu vaccine. Another idea is to encourage your soon-to-be senators. Well, Senator Van Hollen has been there for a while, but all of your elected officials at a state and also at a federal level to support something called the One Health Security Act. And that's planned to be reintroduced in Congress next year. That's coming out of Senator Gillibrand's office, by the way, from New York. The other option is to create a similar One Health Security Act for Maryland. And the template's already there. It's already published online. You can also increase funding for television and online public service announcements to educate the public on protective measures. It's important to avoid raw milk. It's important to report that you've been to a farm and now you're showing signs of illness, things like that. But here's the kicker. If we start to educate people about public health risks and One Health earlier on in their life, then it's going to be an everyday acceptance. People are going to be sensitized to such knowledge and topics that they're not going to fear it. And if this type of knowledge, if we use the pre-bunking technique, then you're not going to be dealing with too many myths in public health, or at least I'll say as many myths. So here's the question for you. What do you think is the difference between pre-bunking and debunking? Talk about jargon. In the communication world, pre-bunking is a word and debunking is a word. Can anybody fathom a guess? And if you want to type in the chat box, then Shane can unmute and read it.
Can you say that again?
Just proactive versus reactive.
Proactive, yeah. Pre-bunking versus debunking. Pre-bunking is educating someone before they hear a myth. Debunking is after the myth arises, right? That reminds me, just to make sure everybody understands the difference between misinformation and disinformation. Misinformation is a simple oopsie. I got it wrong. I misspoke. I didn't mean to say it wrong, but I misspoke. Disinformation is, haha, I got you. Okay? I purposefully spun the narrative in order to manipulate your actions. That's disinformation. Misinformation is oopsie. Disinformation is haha, I got you. Okay. So pre-bunking versus debunking. If we educate before there are bad players involved creating myths about different public health activities, well then it's going to be much more efficient, right? So pre-bunking is the most efficient method between these two. Okay, so tuning into this very last bit, how on earth could we get information about public health and One Health into classrooms throughout Maryland? Well, something to think about is every single state has these standardized exams. If you just include a few One Health classes or One Health questions, that is, into these exams, then it will ultimately require the teachers to teach about One Health. And that brings me to One Health Lessons. It's an organization, a nonprofit 501c3 organization that I created several years ago. And the whole purpose of it is to improve the communication skills of scientists, engineers, and adults in general who care about One Health, but at the same time, educate communities about One Health. Because if communities are educated about One Health, then they'll understand the purpose of vaccines, right? They'll understand the purpose of wearing masks, things like that. So taken from the classroom, at One Health Lessons, we go into classrooms and we teach about various conditions that affect public health. But we do this in a fun way. Here you can see me, this was back in 2018, I think, teaching about vaccines to children in the classroom. So this just blossomed into a global nonprofit organization. And we have a Train the Trainer program that focuses on improving public health communication. And the way we do that, like I said, is to bring public health folks, scientists of different backgrounds, engineers from different backgrounds into classrooms for them to teach about One Health. Because after all, kids are very, very honest in their feedback. If they don't understand something, they'll ask you. When you speak to a policymaker, a politician, and if they don't understand something, do you think they'll ask you? Probably not. So the best audience when you're learning to improve your communications style and skill is really to teach children. And so we have a teacher survey throughout our Train the Trainer program. And the teacher surveys have found through a massive survey that we did in 98 countries that ultimately the vast majority, over 90% of classroom teachers that responded to us said that they want to continue teaching about One Health after having just a single lesson taught to them. 97.4% said that they want to share these lessons with their colleagues. And a whopping 99.1% said that these classrooms showed an increase of student interest in science, which is absolutely outstanding with just a single One Health lesson. To show just an impact of a single volunteer with One Health, this is Charles, who at that time was a final year veterinary student. He took it upon himself to bring 20 of his friends together, train them how to teach these lessons, and then from there, over a course of 2 weeks, taught over 2,000 children. So my question to you is, do you think this is feasible in Maryland? Charles was in Nigeria. So think about the power behind educating the public and, more importantly, K to 12 students about the power behind One Health, that connection between our health and the health of the environment, animals, and plants, and that One Health approach, teamwork. Right now, while we wrap up this year, we are still currently looking for more and more classrooms to teach, either virtually or in person, because we do have a lot of volunteer trainers in this area of the country. So how can you, if you want to improve your public health communication skills, how can you do it? There are some solutions. There's Toastmasters International, which is a communications club. They say that they're a public speaking club, but it's so much more than that. So I recommend just looking at the Toastmasters International website and you'll find the closest to you. Other public speaking opportunities, of course, exist. You can always speak to a Rotary Club near you, just to mobilize passionate people about public health concerns and actions. You can join the American Public Health Association and then enter into their One Health group. And of course, you can go through our Train the Trainer program. So there are lots of different ways to improve communication, but ultimately it is our responsibility as public health servants to improve our communication. As much as we know in our brains and we talk amongst ourselves in our niche, we can't truly hit our target if we can't communicate well, right? So last but not least, I'd be remiss to mention every single January it's One Health Awareness Month. And there's a social media campaign that happens. If you go on the onehealthcommission.org website, you'll see not only this calendar, but you'll also see some helpful links to stimulate some ideas of what you can push out through social media, just so that people can have a better understanding of what One Health is. Okay, let's move on to the workforce. Now, thinking about that One Health approach, here are just a few ideas of where to start. On a local scale, we could think of having something like One Health clinics and prioritizing One Health clinics. So to say that One Health clinic is when there are physicians and nurses and healthcare providers working with people, as well as veterinarians and veterinary technicians and veterinary assistants working with animals all in the same spot. I have had the great fortune to volunteer several times when I used to live in San Francisco in California. And there, the underserved community was immense. We had a very large population of people experiencing homelessness, and a lot of those people had pets. Similar to that woman during the wildfires who said that she lives for these pets, for these animals, same thing was heard with these people who have been experiencing homelessness. So, how do you get people to go to their doctor or have access to healthcare? One way is to have an avenue for their pets to also get examined and vaccinated and cared for at the same time as them and their families. So something to think about. There are several models available throughout the country, and something to think about for Maryland if it doesn't exist yet. Now, again, One Health is not just about disasters, but it is an opportunity to show that people from all different backgrounds are very important to bring to the table. It's very important to bring veterinarians, animal shelter people, so scientists from all different backgrounds, engineers from different backgrounds, and more to plan for disaster preparedness. Because keep in mind, people stay home for their animals, okay? People put first responders at risk because they want to stay home for their animals. Also, during disaster preparedness training, it is well worthwhile to bring the training to one place where all different healthcare providers, veterinarians and their teams, and physicians and their teams going to the same building and learning at the same time. That builds bridges. And similarly, if there are clinical health conferences based in Maryland, if there's a way to incentivize those conferences to give continuing education credits, that is well worth it for both physicians and veterinarians. It's a great way to attract them to the same room at the same time. Okay, last but not least, when it comes to funding. Now, I spoke about the One Health Security Act briefly before, but I just wanted to make sure that everybody's aware that it could be a model that can be served and implemented in Maryland. Now, I don't know Maryland government as much as you, of course, and I'm not pretending to. My role here is to make sure that you're aware of a template that's available online. If you just type in the One Health Security Act, Gillibrand, then you'll find it online. But here's just the basic bits from the One Health Security Act. And the important thing with this particular act is that it focuses on a very innovative way of funding public health efforts. So in this particular bill, there is an interagency policy council that is comprised of people representing all different agencies. Okay, lots of different agencies are involved. And there is a rotating chair. The council ultimately votes on supplemental money that the government has set aside, and we'll talk about where it's set aside shortly, but it's set aside for funding projects where multiple agencies collaborate. The way to truly get the supplemental money is to prove that these agencies collaborate, to prove that there's a public health impact, and to have a sufficient vote at the council level to mobilize these funds. Now you might ask, where are these funds? Well, that pot of money would be situated at the federal level at OMB, Office Management and Budget. But in Maryland, it seemed to be, and I could be wrong on this, so please correct me if I'm wrong. It seems to be that the equivalent within Maryland is the Department of Budget and Management. So if there's a pot of money tied to, for instance, the Maryland Department of Budget and Management, but it cannot be touched until there's a vote from the council, then that money can be dispersed to help multi-agency projects. That's going to skip over, circumnavigate traditional red tape that is well known in government. This can mobilize funds much faster during times of emergencies, and it can also help during preparedness efforts. So taking this act and thinking, how can it improve public health? Number one, it saves time. It avoids the red tape. It moves funding where it needs to go right away. It builds relationships across different agencies. It allows for opportunities to build trust as well. Because ultimately, in order to get this supplemental money, you must work together. It's like leading with a carrot rather than a stick. This also saves money because it reduces redundancies. Well, what I've seen in federal government is that there has been a lot of redundancies when it comes to people not knowing what other people are doing, and they're doing very similar, even parallel work. So ultimately, if we think of bringing people from all different backgrounds together, all different agencies together, we inspire them to collaborate closely, then that in itself is taking the One Health approach. And that can save time, that can save money, and that can save and protect lives. And not just lives of people, but lives of animals. So ultimately, One Health is not just about disasters. It's an approach to protect public health. It's a way to save enormous sums of money through both removing redundancies and synergizing different agencies. Think of it as a mindset. You see the world in a whole new way. It's a mindset, and that is something that must be learned early in life. So if you go to the book, I had it, here it is. If you go to the book, The Art of Science Communication, you're going to see at the end of the book that there's a sample One Health bill that you could use as a template in Maryland. So at this point, I wanted to thank you all for your attention. Thank you for participating where you did, and I am open to questions.
Thank you, Dr. Thompson, for the rich and insightful presentation. The room will on it. You can also type your questions in the chat box.
Other geographic areas. Thank you. It was a great presentation, very insightful. Are there other geographic areas that you're able to share? I saw the example, but of a public health department, a local public health department coming together with the state department. Do you see this working for So local to local, local to state, state to federal, like,
Great question. Thank you for that. So local to state seems to be the most direct route. When it comes to state to federal, when I have seen One Health actions really take place, it's more during emergencies, but not necessarily as much during preparedness efforts. But when it comes to local to state, it's much more impactful, because when you're talking with the policymakers, then you can speak to the constituency a little bit more closely, and that in itself is quite powerful.
no, we always say, I mean, healthcare is local, right? And especially in the next 4 years, I think, figuring out ways that, we can do more work locally, because in some of the work that we're thinking about around public health, funding may be cut. So how do we work more in the neighborhood than we do in the cost? But I was just curious about your model, and if you had any recommendations as to how to do it better, local to local, state.
I
Thank
can
you.
say, yeah, thank you. I can speak on California, because that was the state that I lived in before living in DC, and then before moving to Virginia. I mentioned that I was deployed as a responder in the Veterinary Medical Reserve Corps. That started off as a subset. I think it was a nonprofit, and then it got merged into UC Davis. And then UC Davis got funding from the state to grow it even more, but that was after I left the state. So that was my understanding. If there's more public-private partnerships, I've seen that happen more and more in the One Health space, but thinking about specific examples, that would be it in California. That
And how much is your class cost to do the trainer? Is there a
Oh,
fee for that?
yeah. One Health Lessons is the nonprofit organization. It's an educational nonprofit organization.
So does that mean it's no cost?
Pardon me?
So does that mean it's no cost?
It means that, so it's no cost to the trainers as of right now. And as of right now, there's no cost to the teachers. That's where we're standing as of 2024.
And the classes are virtual?
You said virtual? Some are
Classes are-
virtual, some are in person, depending on
Okay.
where trainers are located.
Thank you, Jane. Are there any other questions?
There's probably more questions internally. I do think a couple things here. One, that sort of public-private mechanism for being able to sort of quickly engage makes sense. It sort of echoes the public health trust. I think that. The second is the power of engaging the schools, and particularly the food and nutrition department. Does anybody, do we ever talk to them?
Locally.
Yeah, it's at the local.
I mean, we monitor their food. I mean, cafeteria is monitored by the local health department. Yes, set up a food students, but for a school, every jurisdiction has a school wellness council that's by law requires involvement of the superintendent or their designee and health officer. They run the school wellness council. So a lot of food and nutrition issues may arise through that council, and then that gets then forwarded to the Board of Education or Health. There's a lot of engagement on school health and school wellness from the state health department as well, and a whole team dedicated to that interface between school systems and public health. And there are a lot of laws and some are regulations that stipulate responsibilities of local health departments as it pertains to school health. And some local health departments are actually the employers of the school nurses in their school systems. So they're pretty, there's a lot of engagement. I think there definitely is an opportunity to engage more on the issue of chronic disease prevention and long-term wellness and health. And I think that unfortunately, the lack, I would say, lack of investment in that area, right? It's true. The lack of investment in that area as it pertains to long-term prevention of disease, right? So we're not talking about, case management of people with diabetes. We're talking about long-term healthy behaviors that, a lot of the previous funding for those types of efforts that was coming federally through states to locals expired or whatever. And there hasn't been much investment or as much attention given, I think, to that as there maybe was in the past.
So here's what I would ask. One, like, I think it's actually public health people, at least involved in City that run the food nutrition department.
Okay.
And it occurred to me, it seems like whenever a net new dollar goes into the education system, it goes to mostly teacher wages. But the impact, it's such a small relative investment. And the healthcare infrastructure is where the benefit of making that investment in Europe. So like if we fed the kids better and taught them about health a little bit better, like in this case, can go together with health. Like it's actually it's actually the insurers that would get the economic economic capture the value of the seniors to
And the workforce.
and the workforce, sure. And frankly, if they did it better, more people go to school on pizza Fridays, right? Which was, we did it really well. It would actually improve their. But I guess like there are, like I know some places like Montgomery County has like a central kitchen and like they're doing more. And like, I guess other places are not. And so is that just local taxes and they can afford it, or what's the?
I'm not familiar with Montgomery County. Is it the central kitchen for the school system? I don't know if there's any probably Montgomery County.
Just gives them like flexibility at the center that they can do like medicine programs. It just gives them more.
It's great.
But
I'd love to hear
Something to add there is that every 10 years, typically, different states, but it's usually 10 years, changes the core curriculum or does updates for the core curriculum. There's also something to flag called the National NGSS, National Grade Science Standards, I believe it's called. And that is something that not all states follow, but I believe Maryland does. So worth looking over those science standards and seeing where public health and One Health can fit into those. Last but not least, it might be worthwhile to think of ways, since there are, it sounded like, if I heard correctly, some nurses who are affiliated with the government going into classrooms. If that's the case, then maybe it'd be worth having a training program with these nurses in order to have them bring lessons about One Health or public health in general to the school, because this is already a trusted member of the community in these schools. So something to think about. Thank you.
On that question, because that's certainly something as a commission, as we look to the public health system overall and the role of state and local government entities in that public health system. One potential area of recommendation could be around school curriculum and how local and state health departments are engaged in the establishment or development of school curriculum, because it's not just the and I don't mean to say just, it's not only the One Health kind of principle, but it's really the overall concept of health literacy. And we saw, I think, or at least we attributed during COVID, some of the disinformation based to a lack of scientific understanding, a lack of health literacy, and so forth. Is there long-term or evaluation data around the curricular aspects that you talked about with One Health? And if so, how would we be able to access
Okay, so we at One Health Lessons have been the first in the world to do what we've been doing. So our data is until back of 2020 for our formal data. We've been in classrooms since 2016 technically, but our paper, and I'll put it in the chat box, of the impact of our paper has been immense, and it's been seen homogeneously throughout the 98 countries where we have been teaching. So in that paper, it said the impact on the interest of science, as I had mentioned. It illustrates the interest coming from teachers themselves, and much more, especially with demographics. So I'll post that in the chat box. Also, apologies, I misspoke earlier. NGSS stands for Next Generation Science Standards.
Thank you so much. I think your presentation really enhanced the value of private partnerships, I think, and also the partnership between non-governmental organizations, so certain entities, especially with regards to promoting the health in our schools and the environment. As different conversations have been had about how not just One Health, but so many organizations can partner, right, to inform health, especially in schools, right? And a lot of the lessons that you spoke about, I want to provide examples of how that can happen. For example, the food focus, One Health lesson, the water focus, all of these are very, very relevant. You want to catch them young, right? You want to get people healthy while they're young. And it all starts from the school. It starts from home, but it also starts from school, right? So I think there's value in this. And as Nina mentioned, there are, certain opportunities to provide recommendations. Thank you so much. Please, can we give her a round?
It's a pleasure. Thank you again, everybody. And you're welcome to find me on LinkedIn or by email. Thank you again.
So awesome. So this is a great time for the 10-minute break. Use the time to stretch and get some refreshments. For those online, turn up your mic, mute, and grab something to drink. So we'll be back at 3:12. Okay, we'll be back, and when we come back, they will have a deep dive presentation from our funding work group. And after that, the rest of the agenda. Thank you. See you at 3:12.
Yeah, thank you. Yeah, yes, we're gonna have a meeting set up to do like orientation on it. Yeah, that would be great.
Of our agenda, which is the funding work group's presentation. We have a special request by the coach, one of the co-chairs of the funding work group, Dr. Polsky. Yeah. Okay. Thank you. All right, please go ahead. Thank you.
All right, well, thank you all for inviting me to present on behalf of our funding work group. Buttons are not advancing.
Oh, no. Okay. Well, wait a minute.
Right, please. All right, so, first slide,
A little louder.
James might have to turn it down just, because I'm sorry, but I can compete with a lot of people. I cannot compete with the godfather of soul. That's asking a little bit too much. Again, I want to make it very clear that what I'm going to present today is very much a team effort from our work group members. I have been extremely impressed with the amount of participation, amount of input. Our meetings are always true team meetings when we get together. The first two slides, next two slides are just the pro forma stuff. What's our charge and what parts of the statute does our work group address? So let's get into the heart of things. Our work group has been very aware that there's a bigger picture to public health funding, and so I want to take a minute or two to go through some of the big focus of things. So we all know that in the U.S. we spend inordinate amount of money on healthcare relative to other economically developed countries. We spend 2 to 3 times more per capita. To put that in a little bit of context, we spend about $2.5 to $3 trillion a year more than we really should if we spent at the average of other economically developed countries. As much as we spend on acute care, we underspend on public health and public health investment. So you can see that on the slide that it's been estimated that we underspend nationally by about $42 billion. I can put that in a little bit of context as well. If 1% of our healthcare spending was shifted over, then that would make up this entire gap. And despite the enormous amount of money that we spend on healthcare in this country, we rank toward the bottom of all the OECD countries. And these are not just like Japan and Switzerland and Germany and France. These are countries like Hungary and Cuba, countries that we would not think that we would be actually below in a lot of health metrics. So we get a lot for not a lot of bang for our buck. Public health, the value of public health has been recognized really since the founding of this country. So to quote Benjamin Franklin, who always put things better than everybody else, public health is public wealth. Again, looking at the big picture, hospital care is the single largest place of expenditure. About 1/3 of every dollar that's spent on healthcare in this country is spent within hospital walls. And that accounts for more costs than physician services, prescription medications, nursing care facilities, and home healthcare combined. And to give some perspective on public health funding, the U.S. spends more on health insurance administration, not on health insurance, just the administration of health insurance, than we spend on all public health efforts combined in this country. So I'll get back to big picture later. We also looked at incremental improvements in funding. So looking at functionality of grants administered by public health agencies at both state and local level, better coordination at the state level between HR requirements and resulting salary costs and core funding revisions. And then we looked at a few novel things, including new ways of identifying and procuring grants, new partnerships with philanthropic organizations, and greater accountability and objective outcomes from community benefit spending. The work to date, I'm very happy to say that at all of our meetings, more than 75% of our membership have attended. Our group is somewhat heterogeneous, and so everyone's public health experience is a bit different. So at the first meeting, I did an overview of public health funding. At subsequent meetings, David Davis, who is fiscal staff at MDH, did an overview of public health funding at the state level. Becky Jones, who's health officer in Worcester County, did a presentation on core funding. And then at a separate meeting, we had the director of MDH Grant Division give a presentation on public health grant management. We devoted 2 different meetings to community benefit spending. So the 3 talks listed on there were split up over those 2. First, we had an academic presentation from Dr. Zare at Johns Hopkins School of Public Health, who specializes on community benefit spending. And then we had presentations both from the Maryland Hospital Association and from the Health Services Cost Review Commission. And then we also had 3 presentations at subsequent meetings from representatives from philanthropic organizations across the state of Maryland. We examined more resources in this, but I just gotten back from 3 weeks in Japan, was a bit jet lagged, and that's all I felt like putting on the slide. So on to the next topic. So with health equity, we'll say that I think in general, this is one area where health equity has been addressed to a pretty good degree. There's always room for improvement, but we see a lot of grants and have seen a lot of grants over the past decade that are purely focused on narrowing health disparities. And we see in a lot of other grants that it's a necessary component of filing for that grant or filing for that funding stream to demonstrate how health equity will be a component of those efforts. Core funding is one of those notable examples, and I'll get back to core funding in a bit, where health disparities, health equity, social determinants of health are not factored in at all. And Office of Minority Health and Health Disparities, which is a relatively new division of MDH, I think, compared to others. I think so. It's still in the process. Most of their efforts have been funded or have been focused on race and ethnicity, and that's understandable. But there probably is some room for improvement with the grants that they issue to think about things like geographic disparities, especially with access to health. Initial themes, we were told we couldn't present more than 7. I kind of lost count of how many we came up with. So we narrowed it down to these. The first, again, getting back to the general underfunding of public health in the US. And I'm not going to reiterate what I said before, but again, as we talk about other things, we have to ask ourselves a question. If all we're trying to do is optimize what we have right now, how much progress are we really going to make? And I think the other is, I don't think the answer is more funds for public health de novo. We spend way too much on healthcare in this country. I think the better question is there room to reallocate from acute care over to preventive care? Second theme is instability of public health funding. Main sources of public health funding are federal grants, state funding, county funding. Both MDH and local health departments have no or very, very little direct control over any of these funding streams. And I'll just say what needs to be said. Public health is just not a priority and probably never will be a priority of any president, any governor, any Congress. And so when we see an influx of money coming in, it's usually something very specific, narrowly focused. So, opioids are a good example, and obviously when COVID came around. But nobody gets elected to office based on their public health platform. And leading to further instability are shifts we see with macroeconomic downturns. For those of us who are around 2009, 2010, public health got cut as much or more than anything else and was the slowest to return to baseline. It took well over a decade until funding just got back up to the 2008 levels. And we've seen a more recent example with core funding where it was cut at the state level recently. Sometimes it's not so much that governors or presidents don't have the right intention, but there's always conflicting priorities. So things like education, public safety, child poverty efforts. And again, people do get elected sometimes on their education platforms, but rarely on the public health platforms. And then we have politicians who tax cuts are a priority, and it's hard to increase funding when you're having taxes. Short-term grants are discontinued or can be discontinued at the end of any fiscal year. I guess we'll get actual data probably from the surveys that are out there circulating right now, but I would just roughly estimate that 90% of grant funding at both state and federal level are 1 to 2 year grants. So it's extremely hard to do true planning. It's also impacts staffing when staff know that they may not have a job a year or two later as they decide on their long-term plans. And core funding, which is often used to support administrative and operational services, is also subject to fluctuations and does not grow with mandatory salary and fringe changes. Updating core funding, local health departments really need flexible funds, and core funds are one of the few areas where at least some degree of flexibility exists. But the core funding as it exists now was developed back in the mid-1990s. So it is sometimes out of step with both needs. And certainly in the mid-90s, it's not that no one was paying attention to behavioral health problems, but it was not at the top of anyone's list of what public health should be doing. We've seen a really dramatic change in the need for public health, or need for behavioral health, and the role for public health in that during the past 10 to 15 years. But by statute, substance use and mental health are not under the allowable spending categories for core funding. And as I briefly mentioned before, core funding doesn't take into account differences in underlying social determinants of health or health disparities. And the funding methodology has not been updated in over a quarter century. And so demographic shifts that happen across counties have not been taken into account. Infrastructure modernization, in terms of the funding group, the two things that we really keyed in on are personnel and IT. And certainly failure to modernize basic infrastructure over the past several decades has made it difficult at both state and local levels to effectively manage financial operations. So the next two are personnel related. The pay scale at the upper level for fiscal staff in particular. If I had to pick one thing right now in my health department where there was the biggest disparity between what people can make in the private sector or the federal government and what we can pay them, state employees, it's the fiscal state. And so it's nearly impossible at this point to recruit and retain well-qualified employees for these kind of jobs. And as a result, we see difficulty in maximizing collection for the clinical services that we run, inadequate oversight of budgets, and increases in rates of non-compliance with grant requirements. And we've seen both at local levels, I can speak personally, unfortunately, and at state levels of how many fines and how many millions of dollars in fines have been paid out by both MDH and by local health departments, not because of any corruption, not because anybody's embezzling anything, but just the staff we have are just not able, either because of the number of staff or the training and the education they have, to be able to adequately monitor and advise the people doing the work. So we end up getting hurt on audits because we don't have people who are properly qualified to do the jobs. And then on the IT side of things, certainly we're dealing with IT platforms that are woefully out of date. So being able to track spending within various department divisions of MDH, oftentimes there might be several divisions working on a similar initiative, let's say diabetes, for an example. There's no way right now that's automated to be able to track how those grants are being spent over the course of the year, unless people can do it. And that means there's delays in recognizing that grants, certain grants may be underspent during the year, and then you're either defaulting and giving the money back, or it's so late in the year, it's hard to use it in a constructive way. So certainly modernizing software, IT platforms in general, would make things much more efficient. And then lots of opportunity for collaboration. Fran mentioned this during her presentation, and we had already started discussing in our work group as well, that there is enormous untapped potential for collaboration between MDH, local health departments, federally qualified health centers, hospital community benefit programs, and Maryland primary care program, and others. So I'll just take a second or a few moments. Maryland primary care program was instituted maybe about 6-7 years ago, and helps primary care practices manage chronic health problems. So I'll use diabetes again as an example. So there are a lot of efforts, secondary and tertiary prevention efforts at both MDH and local health departments. There are a lot of programs trying to do primary prevention of diabetes and secondary prevention, but there is absolutely no coordination, or at this point even attempt at coordinating what's happening in primary care programs and what is happening in public health programs. It seems like there's enormous potential not only for improved outcomes, but probably more efficient use of funds by linking. And you can imagine in other respects for other agencies that I've put down here. And then untapped potential for grant-funded or state-funded collaboration across departments, which I'll get back to in a moment. And then coordination for philanthropic foundations. We have a governor right now who has a background in philanthropy. It seems like it's a golden opportunity to start launching programs with knowledge that he or people that are in his circle would have in helping to foster collaborations between philanthropic groups, either within Maryland itself or on national levels, like the Kresge Foundation, the big Ford Foundation, multi-billion-dollar philanthropies, and again, both statewide programs or regional or local programs. So during the last presentation, Chris brought up a question about school nutrition and school health. There's two facets to this. One, and I'll use asthma, we could use nutrition, but I'll use asthma as an example. So asthma is the leading cause of school absenteeism, particularly at elementary level. We have people at MDH who are health and medical experts, people at MSDE who understand how to actually implement things in an effective manner. You can come up with the greatest ideas in the world, but if you don't know how to implement them, and schools, let's face it, are tricky places to get programs up and running. So what we're talking about are programs that are actually jointly staffed. So you would have a collaborative team of both MSDE and MDH staff. And not only, again, would that potentially, MDH has a bit of money to deal with asthma. The schools might have a bit of money for some kind of health initiative, but they don't have enough money either place to run a whole program. Start to fuse that in a way. The work is more effective. And I would say based on grants that I've applied for, when you have those kind of collaborative programs, funders love that. And I think it would make us as a state eligible for a lot more grants that currently we are not able to apply for. And you can look at reentry services with jails and state prisons, about Department of Public Safety with parole and probation, DSS under DHR, and then either at state or local level with MDH. I'm not sure what has or hasn't been done between Maryland Department of Transportation and MDH when it comes to non-emergency medical transportation, but we know that is always, that's a perpetual problem of how to get people to medical appointments who otherwise lack transportation. And then I think it's an untapped, for our group, I think it's an untapped opportunity with County Office of Aging and looking at more efficient ways to get programs that would benefit Medicare beneficiaries and especially dual eligible Medicare beneficiaries, because that also then feeds back to potentially saving money for state Medicaid expenses. Theme 6 gets again into the innovative. So when I have given presentations over the years to my county commissioners for Board of Health, I'll talk about the flu, and I'll talk about the health goods of getting vaccinated. I also talk about how much money it costs businesses every year and lost productivity when people are out sick with the flu. We know that for problems like alcohol abuse and many other health problems, that the economic effect on businesses because of lost productivity, because of employee turnover, because of workplace accidents is actually greater than the direct medical costs. If we can start to make some progress on these sorts of things, it benefits our businesses. And our businesses have some skin in the game. There's no reason that we can't look at potentially developing some kind of public health business advisory board that the businesses themselves would fund this. Again, expecting more money from the state legislature or for the governor to fund, or that we're going to get more money from the federal government, limited prospects. But here's something that you can make a legitimate case to businesses that in the end, this is going to save them money. Not to mention, hopefully appealing to a bit of human nature, some good that they're actually helping some of their employees. So we've tossed around some ideas, and I will say that this is not a recommendation at this point. This is very much here's an idea that our work group members feel is worth discussing, and we really want input over the coming weeks, months from the commissioners, from other work groups, as to if this idea is worthwhile. How do we at least make proposals that are going to be as effective as possible? So we came up with an initial list of potentials. So local and state chambers of commerce, large employers, Maryland Retailers Association or other small business representatives, labor unions, MDH secretary designees, health officer designees. So there's I think there is a lot of potential here. I can see this starting out with a specific health issue like alcohol or substance abuse that clearly impacts businesses on a day-to-day basis. And if you can make it work for that one health issue, then it becomes a springboard for others that business leaders may not see as much of a direct impact on businesses. And then final theme is community benefit spending. So I think this is the poster child for there's money out there, and we spend it more effectively and in a way that will benefit public health. So community benefit spending in a nutshell is a requirement for all nonprofit hospitals across the country. Every acute care hospital in Maryland is a nonprofit entity, so it applies to every hospital in Maryland. The idea, and this is in Affordable Care Act and in IRS code, the idea is that the money that hospitals save on the basis of being a nonprofit entity, which means they pay no federal tax, they pay no state tax, they pay no local sales or property taxes at all. When they need bonds for capital improvement, they get lower interest rates because they are a nonprofit entity. And all those charitable foundation events that they have, probably nobody's donating to them if they can't write it off on their taxes. So all of those are benefits that hospitals get as a result. And that amounts to, according to the Maryland Hospital Association members, about $2 billion a year that should be spent on efforts in each local community. The HSCRC sees the numbers a little bit differently, but they still come in at 1.4 billion. Either way, this is every year. This is not subject to the whims of what a Congress or a legislature or a governor or a president want to do. Revenue that flows through hospitals is about as ironclad as you're going to get. So whether you want to pick 1.4 or 2 billion a year, that's money that will be there every year. It doesn't run out after a year or two. So this is money that if somebody came up with, all right, here's a 5 to 10 year to really tackle diabetes in our community, or whatever the subject was, you can really start to make long-term plans because you know there will be consistent funding over time.
What is the budget for public health in the state?
I don't know what the total budget is, but I can say what I can say about this. I'm hoping that maybe through these surveys we'll get that number. But it gets a little tricky because like at my local health department, about half of our budget is providing clinical services. It's not what most people would consider core. It's not foundational public health services. And the reason that we do that is because there's no private providers for those kind of services. But what I can say is I know what my local hospital claims in terms of their community benefit spending every year, and I know what our budget is for our foundational. And community benefit spending is way more than twice what we get to spend for all of our foundational.
So it's like,
I mean, it's not.
but this is not actually, they're not, like, that's not real public health spending.
Not at all. That's subsidies for, for,
It's a plug.
So,
it's a plug, it's subsidy for specialists in ED. It's for GME. I mean, there's a lot of, you see the pie chart that HCRC has. So public health is not one of those slices.
so what Maryland law defines what it should be is planned, organized, and measured activities. I have asked,
Don't worry, we're gonna take the comments and questions after the presentation.
oh, and I'm okay either which way. But
Yeah.
however the chair wants to run things, but I don't mind interruptions, but either way. So I have tried to get hospitals planned, organized, and measured activities. I have not been able to. And Maryland Hospital Association will not provide that information either. So I can't say whether hospitals are actually complying with what they should, but I can say they have not demonstrated compliance with what they should be doing. And because they have to actually fill out IRS forms with their 990Hs, and they report certain things to the HSCRC, they self-report on average, a 70% overhead with their community benefit spending. I will say that for local health departments, I think MDH, typically our overheads capped at about 7%, and sometimes we can go as high as 10. And so, again, I've made efforts to find out, give me a line item, show me where this money's going. And I know that there is no planned activity. So, it is probably worth taking a look into to see if there would be some way to have collaboration between public health agencies and hospitals and how this money will be spent, like true plans and a little bit of sunshine coming in to see where this money is actually going. Or maybe shift gradually some of that money over to public health, still letting hospitals keep most of it. But, shift some because, again, as mentioned, even 15, 20% of what is supposed to be spent at a local hospital would increase local health departments' foundational capabilities by at least 50%. And this is where the money's supposed to be going, is into the benefit of the communities. So for continued exploration, I guess remaining questions, the biggest single thing is that we anticipate that other work groups will have recommendations, or the commission will have recommendations that will need funding, and we're just not sure what that is at this point. So it's difficult or impossible at this point for us to come up with plans to move ahead or how we can incorporate those ideas into the work that we're doing right now. And I think that the two groups we're most interested in are data IT, because we presume that's going to take money and workforce. And then input requested. So questions for us to you. Given current state budget concerns, do you think additional funding is available for public health efforts, or will funding new efforts need to be reallocated from existing health-related expenditures? So you can look into your crystal balls there. And then again, how will other work groups' recommendations impact public health needs? So over the next 3 to 6 months, we're going to have representatives from Maryland Medicaid come in. And I would, along the lines of wanting to have a better understanding of what's going on in other work groups, if we can, I'm going to try to arrange for 1 or 2 people from each work group to come in and talk to our work group members to see how we can collaborate at this point. All right, fire away.
Yeah, let's take this. It looks like they still have more. Please, sure. Okay, please.
I think this is, you guys just really hit big themes. And this is great. I just have a couple of questions. One, I didn't see, maybe I missed it, but I didn't see a lot about increased capture of billable services. Because we're trying to look at now the things that we can actually bill for. But the problem is that money flows out of us, goes to the state, goes to the county. So we would keep a small percentage of our billable services anyway, even though we might be able to be much more sustainable. So that's sort of my question and how if you looked at that, and is that something that you think is merit? And then my second question is, and I love the idea of the pool benefits that goes, but I don't legally. I would ask you, how does that flow? Could we get the hospitals to agree to flow some of that money into a population health trust, for example, or some part of money that then flows into the hospitals, into the public health system, somewhat shape?
It's not a real budget. It's a plug.
I'm not saying anything. I will say something. So I've talked to people at a few different hospitals who this is what their job is supposed to be. And that's what they tell me, that there isn't a predefined, like you don't get your budget at the beginning of the fiscal year. Things are just cobbled together as the year goes on.
It's the work they're doing that they're not otherwise paid.
Right. For the
So that I think the answer to that question in terms of how you get hospitals to do it, honestly, I think it's going to take legal requirements. I could be wrong. That's my opinion. Chris, go ahead.
I think if you take on the hospitals, you're going to lose. So like they're so popular for myriad reasons. Yeah. So like I think that two things. One here, if you just cry for and say underfunding versus say high ROI opportunity, right? I think that those two messages go across way differently.
Absolutely.
And somebody like honestly, you would know better than I do, or probably in public health people, because you've seen the messages that work and ones that don't. But I don't like. I think we need to find the common ground, because there's folks like Dr. King that are truly like the public health people and they're hospitalists, and they are increasingly going to be held accountable for public health. And I think this head model and finding common ground is going to be better than just saying give us part of your. It's give us part of your budget, but in order to do diabetes, hypertension reversal, in order to do maternal health, maternal morbidity reduction, in order to do infant mortality, it's basically will help you achieve your goal that now you have to do in order to get paid.
The minute they open their books and show us how they're actually spending the money is the minute I'll start to believe that the money's being spent in the way it's intended.
So I would just add to that is I think that attempt has been made, and so, at least locally in some jurisdictions, we've had specific conversations like that, like particularly around sustainability of initiatives that are established that have the mutual benefit that we're talking about, population benefit, that have relied upon grant dollars, for example, from CHRC. That we have to demonstrate an ongoing sustainability mechanism once those grant dollars go away. And we, in many jurisdictions, I think these conversations are happening. This is an opportunity to invest in improved health outcomes, which will ultimately decrease burden on the population and then also on the hospital acute care setting.
What I'm saying though is we have to make sure the hospitals are paid for what public health wants to do. Like, so if we can focus on outcomes that are measurable,
right?
Like the diabetes, the chronic illness, the state health improvement plan that you guys are talking about.
We have local health improvement plans as well.
But if the hospital, we're about to change how hospitals are paid,
right?
Have to influence that in order that they get paid for making the community healthier. And then how do we get into that value chain as local health departments? So that and that mechanism so that we can get a grant from the hospital to do X, Y, or Z. That's, you see what I'm saying? Is that we have to get upstream of it. And same thing with Medicaid. If we change how Medicaid is procured, we've got these 9 plans. They're big budget plans. We have to insert ourselves into the RFP so that Medicaid, in order to be a valid Medicaid plan in Maryland, you have to do XYZ. You have to be providing X, Y, and Z service for your community or whatever it is. And who is the best? Like,
But I think with the MCOs, it's more of an accountability issue. I think there already, and I can't go exhaustive, but there already are requirements. It's just a question of are the MCOs actually fulfilling those requirements, and including things like for maternal health, decreasing maternal morbidity and mortality. I will say that the people that we help manage, their MCOs do.
What was the last part of the survey?
They do basically nothing. But it's not that the requirements aren't there. I mean, it's embedded in their contracts. It's just that nobody holds them accountable.
my understanding is that there are certain requirements that they actually get incentives and penalties for, and others that they just have to report on. And so it's a matter of just double clicking on which of these things, and that's all in their contract. So the state Medicaid has that power, and the HSCRC has the power of the hospital. So if we keep losing every time, just going to general funds, we have to get creative and go a different way, because
Absolutely.
the definition is the end of it all.
Just turn back to my first.
Yeah, your first question. I was going to ask, so are you saying that when you bill for, let's say somebody comes in for a reproductive health visit, are you saying that some of what you collect is going to the county or the state?
Depends on the source, but if we are, like, for example, the nurse monitoring program or the AIRS program,
Okay.
that money bill, and it goes, a lot of it leaves our health department because it goes to the county, and then most of it goes to the state. Most of the things we go to the state. If we do clinical services, some of them stay within us. But a lot of the services right now, that also is in part due to it's a state position. The state gives the money to the physician, then they're technically paying for the work done. But that's a little bit of a different model, but we send the state and the county, which could then actually generate a lot of revenue for us that we could invest into our.
And is that specific to AIRS, or like if somebody comes in for a reproductive health visit, is it the same thing for that?
I have to check on which source goes. I don't have enough detail of which source goes to which.
Okay.
But I do know collectively we give a percentage, most of it to the state.
Okay. AIRS is kind of a quirky program, but I know that for our other clinical services, we don't give any of that money to anybody else. I'm just, we can talk a little bit more afterwards and see if this is a Prince George's issue or this is a more general issue. Okay.
Well, first, I use that your focus on, and this is really solid, and we've got like 8 different, something.
7.
7, I was busy, but yeah, it's really, really well done. Yeah, you guys have really dug in and gotten expert. So I don't think anybody's going to argue that probably not feasible to rely on increased funding in general public health in Maryland to fill the gap with public dollars in the upcoming, at least the short term investment, right? And so the idea of reallocating from acute care to public health, that's a thing, and it's great. So that's when it gets tricky, because there's going to be some loose for stuff in the allocation, right? And people are there's more outcry when you take something away that people have used for a long time and money, and they they've budgeted a lot of services which may or may not be aligned with really what either local or state health improvement plans is. But the hospitals have an infrastructure and an inertia to continue to fund that community medicine. I'm just going to tell you from being on the inside now, hospital board, that is funding the machinery parts of the hospital. Now, you may not think it's well spent, but if you pull back, there's going to be a little crack. That's all.
Right.
However, I'm getting some sound like a record, but the AHEAD model is on us right now. So we are in the implementation year. There's 12 months, okay, in this year, upcoming year, in which the rules of the road are going to be written for the next. It goes to 2020.
2034. And so the rules of the road right now are so little, they're going to be required participation agreements by all hospitals, by primary care practices. This is the nuts and bolts of getting in on the ground floor and saying, look, let's work together on this participation agreement with your local hospital or with the hospital system statewide and say, what can public health bring to these very specific goals? It's not going to be all over the place. It's going to be diabetes. It's going to be something for kids, probably asthma. It's going to be something for women, probably internal. It's going to be very like 3 goals. So what can we do? And now we're talking about kind of new money. If in fact the proposal, which is going to be heard by HSCRC next week, goes through, and that is to say we're going to raise hospital rates in Maryland by 1.6%. That accrues millions of dollars, 60 and 80 million of which would be earmarked in the current proposal for the population health trust, which you talked about. So anyway, I think this is the moment, this is the time to really work on some new money. That's possible. Okay, now the second thing, I'll stop, but until we get some kind of repository in the state that is like a trust, a hospital can't give a health department money. It doesn't work. The hospital can't get a grant from the health department can't get a grant from the hospital and do that work as if the hospital is the investor in the health department. That won't work. We need to have independent and a trust that will attract investment, that will manage those investments. We need to have something that is respected, that has integrity, that's neutral, and that can be a repository for if you go to a business. I love that whole business thing. You go to employers and say, hey, Purdue Chickens, we can make you people healthy. They're going to say, yeah, okay, well, I'll give you maybe $200,000, but if it doesn't work, then I'm going to need to do that. So in other words, how can you bear risk? How can you actually get into an agreement, which is very typical in the market for the way health is, without having an entity that can protect or can buffer between the government and the investment? So there's a lot there, but I'm excited about it. They're great.
So
So can I run through a list?
If you can make it concise, maybe like 3 points. It's the last meeting of the year. We're trying to get up here.
can I ask
Thank you.
Fran one question?
And also for those online, please, if you have questions, because I can't see the, the function of the.
So Fran, in the context of the head model, when you were talking about starting to show that local health departments or MDH can benefit the hospitals as they try to reach their objectives, are you saying that we just need to go with ideas, or are you saying that those ideas should draw money out of the hospitals that can be used for those purposes?
So the idea formation work is happening right now. It's begun right now. And largely, the foundational guide, the governing body for that is the Health Equity Commission. Okay. So I just think everybody in this should get involved in like watching that and having input into that Health Equity Commission, because that's where the ground rules are embedded for all these, for the module. Okay. So that's where certain statewide priorities are going to be selected. So unless everybody is doing diabetes in some way, it doesn't have to be the exact same way, but across the state, then the state of Maryland isn't going to be, so everybody needs to get, and actually that's something for the MDH leadership to look at and say, okay, everybody does this. Nice. Okay, it's not easy, but this is what everybody's got to do something in this menu of work around diabetes.
But it's still ultimately up to the hospitals to then do that work. Is that what you're saying?
No, the hospital, well, doesn't have to be. It depends on the participation agreement between the state.
And are you suggesting the hospitals will voluntarily give money to other organizations to do some of that work?
They're taking it part of the head model. They're taking some of that increase and putting it into this trust.
Kind of what we talked about it.
Okay.
Yeah, it's really worth it.
Okay.
But it,
Very good. Okay.
So just I think we have an organizational survey coming out to go to local health departments and the state health department as well. And the organizational survey is going through final edits and everything right now. I know I went through and I provided some content feedback on that survey related to funding that I thought would be important items for the funding work group to consider and potentially make recommendations around. So I'm just going to run through some of those, if that's all right. So one is this concept of the no charge list, which is in policy right now, and then that the secretary adopts upon discussion with the health officers every year. But, you know, this is, I think, somewhat unique to Maryland that we have a no charge list that explicitly states what services a health department cannot charge for, even if those are billable services and we have contracts with payers who are ultimately responsible for those types of services. And there's a reason for that. It's because of, you know, you don't want to create a barrier to public health, but then there's also stipulations around how a health officer may or may not waive fees in times of a public health or financial need. And so I think that might be, I know that conversation we've been having across health officers, but I think that may be worthwhile conversation for the funding work group to have and make potential recommendations around that new charge list. Similarly, well, maybe not similarly, but you know, there's another topic of the billable services, and Matt brought this up a bit with his introduction. Health departments at the local levels, and I'm not sure how the state processes with this because it's a little bit different. Because we do so many billable services to address gaps in our community, particularly I think in rural areas and underserved urban areas, it is critical that we, for a sustainability perspective and for honestly a payer accountability perspective, it is critical that we be able to bill and get reimbursement from payers who we contract with for those billable services.
And that's mostly Medicaid.
Not, yes, but not necessarily. We contract with several private insurers, including the company Humana that now handles what used to be TRICARE. And so the federal kind of employees and contractors, we have a base in our county. So yes, we have contracts with Medicaid payers, we have contracts with private payers, and there are many people that come to our health department who are not Medicaid, who could otherwise have gone to the private sector if they had access.
We have
Because
more
when-
influence over the Medicaid.
Sure, understood at the state level. I'm just saying that there needs to be some accountability of health insurance providers, whether they're Medicaid and perhaps through Medicaid, there's more leverage, and the private sector to contract with local health departments that are providing these key billable services and to provide adequate rates for those services. And I feel like this one-off, each individual health department begging health insurers for contracts and chasing them and now having to go through this SDI process at state, which is, you know, they don't want to comply and do all the paperwork needed for that. And, you know, there's a lot of stumbling blocks in that process. We've made a lot of gains. I think under Fran's leadership, I remember we made some advancements in this area, but I really feel like this is a topic that affects funding and sustainability of effort and puts the, puts the accountability for the dollar where the pocket benefits, right? And so I think that would be a great topic for the funding work group to take on or think about some recommendations in that area if it's helpful.
Can I comment on that before?
Yeah,
we-
please go for it. Interrupt me now, I'll be-
So a few years back, a law did pass that requires every insurer to contract with local health departments.
Right.
Problem is you still need to get the contract executed. So to your point, if there would be statewide contracts, it would make things easier. I know for our local health department, we do have contracts with TRICARE and with Care First and Aetna and United and, you know, basically everybody that the rates, I don't see a practical way to move forward with privates. So a little bit of background. So the chair of HGO who retired from the legislature a few years back, but had a conversation with her as that bill was coming up for debate to require, and this was somebody who was very liberal overall and was very supportive of public health, said that philosophically she was opposed to having the legislature mandate what private companies, who they needed to contract with, and how they need to do their business. And I'm not going to go into details, but there was a lot of conversation as to the practical outcomes of holding to your philosophical grounds on something like that. So the bill passed, but the idea that the legislature would be open to actually mandating a fee structure for private companies is probably not realistic. What I can't make recommendations. So I'm going to get to that in a sec. I can't make recommendations, but one of the things that when we get to recommendation stage is that FQHCs are paid differently by Medicaid than anybody else. My presumption, I don't know what the history was of that, but my presumption is there was a recognition that they cater to an almost exclusively, or at least a highly skewed Medicaid population. And as someone who was in private practice for many years, there's no way in the world that I could make a fiscally solvent practice out of that, the payer mix that is in FQHCs and we have at local health departments. So my presumption is that FQHCs were granted a higher reimbursement in acknowledgement of that skewed payer scale. And I would argue that local health departments should play by the same rules in terms of Medicaid reimbursement as FQHCs. But I can't make that recommendation at this point because we're not allowed to make recommendations.
Right. Well, again, I'm putting forward topic areas.
Yeah, no,
that I hope.
and I agree with them. We've been talking and yes. We're right there with you.
Right.
Is there a way to make this FQHCs? You can just make the clinics.
So there are health departments across the country that you have to apply to be an FQHC. You have to get, it's through HRSA federal level, and you have to have certain qualifying need in your jurisdiction that would justify you being an FQHC. We've actually looked into this, and we actually RSNF worked with our health department to research this topic. Because we were really interested in the FQHC, the health department being an FQHC model. That is something I think that deserves some merit in looks investigating at the state level. There are a lot of individual barriers to reimbursement that come when one singular health department in a state kind of starts to go down that road.
So there are two jurisdictions that don't qualify for FQHCs. And there are about a half dozen that also don't qualify for what are called FQHC lookalikes. I don't know whether, so it would be impossible in my county to do that because the county itself doesn't qualify for FQHC. So that might be beneficial, but the easier route would just be, these are state decisions in terms of Medicaid reimbursement. You don't need federal to weigh in. If the legislature would say, yes, we understand the rationale. And if this is a reimbursement for FQHCs and local health departments are serving a similar population, then it should extend to them as well. This is probably not the budget year to do that, but when the opportunity arises, then I think that is something that deserves consideration.
So one other area to look at is what kind of restrictions might there be and health department billing, and I'll use the school-based health clinics as an example, just because our health department administers and staffs provides medical services through 2 school-based health centers in our county, as do some other health departments, although I think there's a desire across the state to have more school-based health centers. So because of the educational benefit there as well. So there are some restrictions on what we can do with school-based health centers that influence our ability to bill or bill adequately for those services. And so those are things that are policy related, and so that might be something to look at as well as work through. And then I'll just run through very quickly now, precisely as to its perspective or requested. One is the indirect cost rate agreement that MDH has with the feds, MDH has with local health departments. So essentially, there's a very low cap on what local health departments can request as an indirect cost rate. Right now, it's 10%. I think it was during your time, Fran, that it increased from 7.5% to 10%. It's still 10, which is phenomenally low for what the actual indirect costs are to local health departments, which again strains core funding because that's what we're using to fill a lot of the gap there. And there may be some opportunity to discuss that further and so forth, and kind of review what the impact of a change there would have. Another item would be the environmental health fee schedules. So each board of health locally sets their own environmental health fee schedule. I've made some recommendations to the organizational survey to have some questions related to that environmental health fee schedule, and how it's adjusted and how it varies county to county and so forth. So there's probably some, environmental health fees are considered a shared structure between the public taxpayer who gains the public health benefit of those environmental health services, as well as the homeowner or business owner who is paying a share of that cost. And typically the burden on the public taxpayer is far greater than the burden on the business or the household. And so when we look at those environmental health fee schedules from jurisdiction to jurisdiction, if it hasn't been updated in 10 years, it's way behind what, the burden shifts, right? I mean, the burden on the taxpayer becomes even greater because inflation in the past 10 years. So that's another topic. And just to echo something Chris had said before, which I thought was a really, really great point about, I think you said something to the effect of people don't get elected to office, or you said something to the effect of people don't get elected to office because of their public health platform. Well, they do get elected to office because of their economic platform. And I think and maybe this, what I meant to say is that it will cue up something Chris has to share, that I think it's really important for us in public health and to better tie our efforts to economic benefit. How does public health gain translate to economic benefit? And how does public health investment translate to economic benefit? And if that's a core message, what kind of training and skill sets and communication support do local and state health departments need to fulfill that? There's economic evaluation, and there's costs associated with economic evaluation of public health intervention. And that may be something for us to consider as we move forward. Humans.
The only thing I would just add to that is so we've acknowledged that the hospitals are winning. They're very successful. They're huge workforces. They're the biggest employer in almost every jurisdiction. And this is going to be a hard fight and to say, hey, give us your money.
Right.
School education similarly, that they're just good at it. And so we get lots of money. But if you think about the messaging, and you're like, we're underfunded, but our life expectancy sucks. Is really compelling. It's we're the last. And of all of the messages that we've heard that have been most compelling, it was to be more healthy babies. It's who's going to cut money from that ever? It's they invested dollars, they got less dead babies. And it was this clear tie. And it's got 1,000 fathers, everybody's responsible for it. But how do we start? Part of what I think would be a valuable exercise is this inventory. We start, there's more of those stories. The work you guys do here, there's real benefit. And it's just, if we can pull that out, I think that's what we'll get. That'll keep from the top. Eventually get additional money.
Thank you so much for the discussions. Is there any other question online? If you have additional questions, you can send them to us via email or make sure to work with the country worker. Now moving along to the next item on our agenda, I'd like to call on Shane to offer brief updates, and then they'll turn it over to the assessment team from University of Maryland School of Public Health, University of the Coast, and in their area to give us an update.
All right, just a few updates like Tosin mentioned. So we are in the process of reworking this timeline based on the lessons learned from how we went through the interim report process and kind of applying that towards the final report as well as the recommendation development process. So all that to say that really anything after February is kind of up for grabs in terms of what we end up, how we end up structuring that and sequencing those events. And in that vein, we are toying with the idea of adding some virtual only meetings between our monthly meetings to ensure we've got enough time to work through the recommendations and the different report outs and so forth, and really wanting to make sure that we don't feel constrained by just having one monthly meeting for the rest of the calendar year. So not a lot to say concretely there, except that we wanted to put that out there, get kind of your general thoughts. You know, you can send me your ideas or feedback afterwards, or if we have time today, you can share that. But if you see those come through, that's what that's related to. We're gonna, the commission staff are going to have a couple meetings before the end of the year and really make sure that we refine this a bit more. So more to come on that. But in terms of January, what you really need to focus on is that we will have no deep dives at that meeting, and it will be focused specifically on some policy panels from a couple guest speakers, which we're still getting those pulled together, but we've got a good lineup for you. Okay. In terms of work group updates, we wanted to acknowledge that Roger is retiring from the local health department, and so that means we will be having Gina Spear step up as the local health officer representation for the funding work group. Really appreciate Roger's participation and leadership on the funding work group, along with Dr. Polsky. And I know Gina is really excited to be a part of that as well. Additionally, last meeting, we told you that Jay Athenda was stepping down from the data and IT co-chair. Craig Bem from CRISP will be stepping up into that role. And Craig's been on the work group as well. So he's pretty enmeshed with what's going on and is eager to work with Dr. Levy on that. Something that we are continuing to have conversations about based on our last leadership meeting with all the work group co-chairs and the commission co-chairs is just how best to address some of what Dr. Polsky brought up today, which are these cross work group needs and issues, and recognizing how siloed things have been to this point, somewhat by design. So going forward, we're trying to figure out the best way to promote those collaborative opportunities, and maybe looking at things more thematically versus these work group specific silos. Yep, that is all I've got to share with you. So Amelia's going to take it over.
Please, go ahead.
I just want to go back to the, I certainly appreciate the timeline and all that has to be done. And I would say that we probably could be a little more discerning, I'll say, with regard to speakers and duration of presentations and even the comments and questions that we pose. So, I think it's, for all of us, this is a lot, right? Like, this is a big endeavor and it's been great, but the idea of having more meetings, a 3-hour monthly meeting, I think we're on. Sorry, louder. So I would just encourage us to explore ways of being more efficient with the monthly meeting as opposed to adding virtual meetings.
Some of this
Appreciate that feedback.
issue in the sense that we're getting into our assessment data isn't going to be honestly completely finalized probably until March. Yet we have to have a 30-day public comment period. We have to have time for commissioners to consider all the recommendations of the work groups. So you have the assessment, the work groups need sufficient time to consider the full assessment data and then deliberate upon recommendations. Those recommendations for all 5 work groups should then come to the commissioners so the commissioners can deliberate upon them, maybe send them back to the work groups for tweaks if necessary, and put them back eventually. Then we have to post the final recommendations that the commissioners agree to and a draft of the final report, for a 30-day public comment. We have enough time to respond to all those public comments, and which could be hundreds or even thousands, depending on who's reviewing. And then we need time for the commissioners to vote on the recommendations, and time for commissioners, when it's not a unanimous agreement on our recommendations, we need to have time for the commissioners to write dissenting opinions that then get incorporated into the final report. Then the final report, which we anticipate will probably be 400 pages, will need to be completed, approved, edited, designed, and so forth, and then submitted to the legislature by October 1. So if you think about from that period of April through October 1, or April through probably May, right? Because we'll probably need to post for public comment around June. That's only a couple months or a few months, right? And so and that's the time that the work groups are going to be considering and developing recommendations. So how then are we going to have time for the commissioners to hear those recommendations, deliberate upon them, and make decisions on conclusions? And so that was really what drove. So part of what we've discussed is not having speakers presentations at those meetings post-February. We had certain people scheduled, and we thought these were critical to the deliberations of all work groups, in particular the policy panel. And of course, hearing from the NBE secretary is something we've been really wanting to do for many months. So, and we also have an open invitation to the health secretary, Dr. Herrera Scott. We're hopeful she will come back as well to speak to the invitation they have on other aspects of the department. So we're waiting for a decision from her office as to when they'll be able to do that, or to be able to do that. So, but outside of this, what we're really looking for is time for deliberation and to hear the recommendations. So having a virtual interview will likely not be a 3-hour time frame, but I think it is something that we may want to schedule in our calendars, which look out, I know for many of us, weeks, months in advance. And if we don't need it, we can certainly cancel it. But I think the idea was that it's a lot to happen in a very, 2 or 3 months time period. It's given everything that needs to happen for the final report gets published October 1.
Yeah, that's very helpful.
And those conversations are still ongoing.
Yeah.
Thank you. All right, on to the presentation.
Great. Well, thank you everyone for the opportunity to speak with you today and give you an update on where we are with the assessment. I represent my team at the University of Maryland and Anita Hawkins from Morgan State University. We are academic partners to the assessment team, trying to provide sort of an objective bird's eye view of what's going on. And we have really been privileged to hear all of the stories. And I think someone mentioned the importance and the compelling nature of the stories and experiences that will contribute to the commission's work. And we are hearing those stories for sure. So today I just want to review the assessment approach very quickly, give you very good news on where we are with data collection, and tell you what we're learning about. I'm not going to be sharing findings necessarily, that's for February, but I will tell you sort of how we are learning about things, what we're learning about, and provide a suggestion for a framework for how to organize our system assessment and its findings. And then we'll have some time for discussion. So the entire assessment has multiple pieces. This is a daunting task to say, assess the public health infrastructure in the state of Maryland. So it's always easier to break it down into pieces. We're hearing perspectives from the public by doing public listening sessions, public comments, the public survey, and we hope to learn their thoughts, their awareness, their practices. The commission has its work group activities, which you started to see in the interim report. The local health department visits were important in gathering information. The qualitative interviews is what I'm going to focus on today, and the focus groups. But what we hope to learn from that is what is the current status of what's going on in local health departments and state agencies, the whole public health infrastructure. We heard about challenges. We want to hear about emerging issues, models, ideas for the future. And then we have structural assessments that deal with the actual quantitative, describing the system from a more quantitative point of view. All of this and a little bit of pixie dust is going to help us chart the path forward and make recommendations for the future. These are the things that the academic partners have primary responsibility for. So Dr. Hawkins is looking at those perspectives from the public. We are looking at qualitative interviews, which I'm going to share more information about today, including the focus groups and the new organizational survey, which Mina mentioned earlier. So the qualitative interviews were conducted by me and my colleague, Dr. Kennedy, at the School of Public Health. They lasted from 45 to 60 minutes. They're still ongoing, but we're making a lot of progress. We wanted to balance the breadth of the topics with depth. And so we wanted to make sure that it was a dialogue, that it wasn't just a series of questions. It wasn't like we were robocallers. And the direction of the information went in the direction that the respondent wanted it to go, because there were so many different types of people to be interviewed. So who comprises the public health infrastructure? The influencers are the state legislators. The state agency provides oversight, guidance. There's a lot of sister agencies that play a big role in the public health infrastructure. Then there are state agencies that provide sort of a backbone of operational infrastructure, that like financing, human resources, IT. Those are sort of backbone sister agencies. Then you've got local agencies, the local health departments, for implementation of all of these different activities. And then you have advocacy organizations, healthcare service providers, to which the public health service providers link to. And I really enjoyed the conversation about that relationship between public health and the healthcare service delivery system. And then you have other entities like CRISP, who provide data infrastructure to the whole system. So this is our attempt to organize all of the people that we have had the pleasure of talking to thus far. And we have completed 69 qualitative interviews since the beginning of October, which I think is pretty monumental. And it's not just us, it's really the willingness and participation and enthusiasm of all of the people that have spoken to us, and our awesome operational team that organized a sort of a open table system for scheduling interviews, because if we were to rely on doodle polls, it would have never worked. So these are the people that we have interviewed so far. We've interviewed 4 state legislators, 4 county executives, and there's a lot of diversity in urban, rural here too. Advocacy organizations. We have interviewed people at the Department of Health who are leaders. I put 3 people who, Nilesh, Dr. K, and all local health departments have participated except one so far. We're still hoping for full representation. MACHO has participated. And although we didn't interview community-based partners like schools, like law enforcement, like faith-based organizations, like substance use prevention programs and experts, I wanted to include them because we sort of heard their voices through the local health department interviews. And they are such a part of the whole public health infrastructure that it would have been remiss not to include them on this. And I want to also say that when we say that we interviewed 23 local health departments, sometimes that involved 2 people, sometimes it involved 3 people. So it's actually even more people committed to these interviews. At the Department of Health, we received awesome participation from so many different types of people who ran bureaus, who had perspectives on different aspects of content areas that are so important, like preparedness, healthcare financing, the primary care program office. We learned a lot from them. The sister agencies we interviewed the Secretary of the Department of Aging, the Department of Education is scheduled, the Department of the Environment, the Department of General Services, Labor, Occupational Safety and Health, Agriculture. All of these play such a central role in the whole system of public health. I'm not an engineer, but this is a system. This is definitely a very, very complicated, layered system with a lot of partners and a lot of room for creativity, but a lot of room for improvement and tweaking as well. The other entities that we've involved and that are scheduled are CRISP, the Healthcare Commission, the University of Maryland Medical System, the Community Health Resources Commission, and one of the maybe glaring groups of people that we have not interviewed directly are academic partners, like me, Dr. Lushniak, the leaders of academic institutions. So we decided to group them together into a focus group. So it's a different type of data collection where we will be representing the voices of academic partners because they're part of the system too in terms of driving the workforce. We are waiting for responses from a smaller group of people. So I just wanted to include them on the slide. But what are we asking everyone? The probes, like I said, it was not a set of questions where we wanted multiple choice answers to. They were qualitative probes that led the direction of the assessment. And they were tailored depending on the role and the position of the person. But and they were driven by the work group topics like governance, workforce, communication, data and IT. Everyone was asked about their vision for the future. But some of the example topics that were covered included things like the relationships that they had within their department across state agencies, their attention to health equity, how data are being used to make decisions, what strategies they're using to reach their priority populations, their idea of readiness, how prepared do they feel, what were the lessons learned from COVID. We learned about the history of funding streams, their current funding stream models, like I said, their vision for the future for some of those funding streams. But we wanted to cover all of the different topics that were, standard in the work groups, as well as understand the more nuanced view from their leadership positions, what they could speak to. We wanted to make sure that we captured those things. So what are we learning about from the interviews? The way I sort of conceptualize this, and this plays into how we kind of want to report our findings, and I wanted to sort of test drive this today, is if it's a system, the system has inputs, the system has activities and processes, and the system has outcomes. And these are the key drivers of the activities that are being done, and these are the outcomes. So what are the key drivers that we're learning about? We're learning about things like the organization, the internal governance, but we're also learning about those things that you can't really quantify, like dedication to the field, workforce motivation, ability to sustain their operations, the tension that they have with grants that only last 1 or 2 years, right? So we're learning about how they are doing the best they can with the operational infrastructure that they have. We're learning about workforce needs, training, continuing education. We're learning about what is required for the future contemporary workforce. We're learning about funding streams, as I mentioned, challenges with grant writing, successes with grant writing, ability to pull from sister agencies. We're learning about how some of those sister agencies at the state level have gone after and procured grant money from the federal government that may be even underutilized, that may be sources that we can tap to build our public health infrastructure from things like aging, from the environment, from EPA, in terms of there is money available from EPA to modernize septic systems, to modernize our environmental health infrastructure. Are we making the best use of those funding streams that go all the way from the locals all the way up to the federal government? So we're learning a lot about technology and data systems, not just at the local level, but all the way across to the state level. We're learning about activities that are on the ground, as well as things that are being done at the state level, communication efforts, collaborations, and partnerships. And I can tell you one finding: Maryland does not have a problem with forming effective, sustainable partnerships. We are really, really doing a great job at collaborating and forming those partnerships. They are an essential ingredient to making sure that we can achieve the health outcomes that we need to achieve. But without high-level, effective communication, and without regular opportunities and forums for dialogues and real meaningful communications at all levels, and creating a sense of an understanding of the roles and responsibilities of all the different agencies and all the sister agencies, and all how the locals are working with the state and how the state is working with their sister agencies and their operational backbone agencies and the federal government, and the strain that everyone is under without communication of all of those issues. It's really hard to have everything work. It's okay to have things work, but it's really hard to have things work as maximally efficiently as possible. It's like you can play golf, but playing golf well takes a lot of practice and a lot of communication. We're learning also about all of the things that people want to achieve. Health equity is at the top of everyone's list. We want to make sure that not only do we achieve health equity in our health outcomes, but we achieve the workforce that is required to make sure that our workforce is as diverse and represents the populations that we are serving as well as it can. We're learning about emergency preparedness and response and how to communicate health information most effectively to all populations. We've learned that communication depends on relationship building and trust. So I would just very, very heartily encourage you to look across those work groups, because what we're learning about is that everything is connected to each other. It's very hard to say separate governance and structure from communications, or separate IT from workforce. It just doesn't make any sense. So this is sort of an idea that I have for presenting our findings that will give the state legislature a perspective of what is the system in Maryland, to describe its characteristics and to describe the vision for the future in terms of how can we improve the system to be a leader in the nation. Through the focus groups, We are trying to supplement the information from the qualitative interviews by doing a deeper dive on some of those topic areas that we really want to get at. These focus group invitees are being populated using existing group lists or through a nomination form. They're conducted online. We wish we could have done them in person, but time constraints didn't allow that. We're allowing the participants to share additional comments online. These are the ones that we've completed thus far: assessment and surveillance, communications, public health emergency response and preparedness, and behavioral health. Just at 11 o'clock today, we did the behavioral health focus group. So I'm not going to read all of this, but these are the central questions that we're trying to address in each one of these focus groups. And it is a very nice method for supplementing what we're learning in the qualitative interviews, because it's providing a group understanding of some of these issues where dialogue can take place and discrepancies can take place. Is everyone hearing that? The people from urban areas, are you hearing the same thing as people from rural areas? We're getting a really nice mix of people around these topic areas. We have these scheduled: chronic disease, maternal and child health, injury and violence. We've got the nurses scheduled, human resources and communicable disease control. And then only 2 left: environmental health and academic partners. I think the academic partners, we were waiting for the semester to be over. I think that was the scheduling issue. But we hope to have a very robust dialogue about academic partnerships. The organizational survey, Mina, thank you for your exhaustive commentary on that. We have incorporated your comments, and we will be starting data collection next week. That's our hope. But the org survey, again, is going to complement the qualitative interviews, the focus groups, by giving us a more quantitative assessment. Like you asked about, what's your budget? Where are the sources of your funding, right? So in a more quantitative way. It'll probably be necessary, we believe, to have the survey completed in different sections by different people who know the answers. So my team has somehow managed to figure out a method by which that can be easily fillable by different kinds of people. But we really are hopeful that this will provide another lens on the whole system. So I had questions about the timeline. This was the original timeline modified somewhat, where the ongoing primary data collection, including the surveys that we're getting from NACCHO, is going to last until probably mid-January. This is probably ambitious to say that we're going to be preparing our final report then of our findings. But the considerations regarding the rollout of findings has come up in the interviews. People want to know what is being done with this information. Many people are very, very interested to know how this is all going to be synthesized. How will we make the recommendations most actionable? We have been advised that a 200 to 300 page report will not make recommendations actionable, that we will need press briefings, that we will need press releases, that we will need one-page summaries, that we will have to have much more palatable, actionable recommendations that are not nested within an appendix. So I understand the need for final reports that are 200 to 300 pages long, but I think we can do more and more thinking about how we can make these findings actionable for legislators and for policymakers and influencers. So I really want to think about audiences and maximizing the impact of the findings. We've done a lot of work. You have done a lot of work. The work groups have done a lot of work. We want to make sure that it lands well, and that it ends up being a spirited discussion between public health professionals, the public, people who it affects, and people who can influence the direction of public health. So I really, really thank you for your time, and I would be happy to take questions and more dialogue.
There's nothing like this. Going to be for sure a robust model. For
Yeah, yeah, and we want it to be. We want to be known for that, for sure.
This is
Yeah.
superb. So thank you, and Oregon State and all the partners that have been super involved in this process, supporting this process, CDC Foundation and other partners like Development also as well. So one question I had was about the organizational survey, because I know it's upcoming. We're really excited to get it out to the locals, but we also really need to collect that data or some appropriate level of data from the state health department as well.
Yeah, we're confused about that, to tell you the truth, because the state health department has 6,600 employees, right? And a lot of different divisions, and the questions that we're asking of the locals might not be appropriate. So we're confused because we don't know what the format should look like, who's going to be in charge, whether or not we can get some assistance on that. It's not like, oh, we're going to send it to the Department of Health and they're going to know what to do with it. So we want to make sure that it's meaningful and how so I'm just being honest.
Yeah, we can certainly have a strategy.
Yeah, so if we could have it.
Unless you're on.
In terms of strategy, like I think I appreciate the academic honesty and like wanting to do it, but like I hope you guys like know where you want to I would encourage us to have a hypothesis on the recommendations, like in terms of like.
Are you just talking about the organizational survey or the?
I'm talking about our final report.
Okay.
And
Okay.
I think we nailed it in terms of like the 200-page report. People are just gonna, but who's gonna read that? Like I don't know. But the digestible components, at least if we have some ideas on what it is that we want to say, and presumably it has stuff around making these high ROI investments, continuing the ones that are high ROI and making some new ones, and then and if that is the pitch, effectively this is a pitch, right? No, I don't want to distill down the work of the commission but it's effectively a sales tool. And if you think about it that way, we should have an idea of what it is that we're selling. We're selling the public health infrastructure and why it's valuable, right? And so in that regard, I guess a couple things that I would say, having done pitches. Okay, one, I think I'd highlight the work that was done by the committee there in terms of like, if you look at the public health infrastructure and the budget, and you graphically show it as community benefit dollars, everything else. So stuff that way, and then the arrow between activities and outcomes, like that needs to be quantified. It's like, okay, all of this big pool of money is being used to try to influence these state health improvement metrics and pick through the diabetes, maternal health, and mortality. I think the health equity committee is coming around diabetes, right? Is what I think. So okay, the next 5 years, 10 years, we're going to set up this ahead model, and everybody's going to be running towards diabetes. Who's going to do that work? And like we should have at least some hypothesis, or it'll just be like we should know what we want to get at. And I know it's not academically honest, but
It is. But you're on the right track. Yeah,
the other thing,
I hear you.
one other thing again in terms of sales tool, I would look at adding to our list a couple of representatively huge workforces. So maybe if we can find somebody in federal HR, whatever they call it, personnel management. Hopefully somebody's got a connection I know Care First does, but if somebody can talk about presenteeism, 75% obesity rates, like somebody who can like talk about the crisis.
Yeah.
And then we can start creating ROI, like
Yeah.
selling.
Yeah.
How this
Like how workforce productivity is being impacted.
right,
Yeah.
and not impacted.
Okay.
Because it's this tiny little budget here.
Okay.
Then maybe like that's, and then, yeah.
Because it isn't just about dying, it's about living well, right? And being productive when you are well.
And the presenteeism thing, I think, is a very real concern for big employers.
Yeah.
And there's more. I'm not an expert in that stuff, but I know it's an issue. And so are the absenteeism rates and the impact of bad care, and also health insurance budgets. Like they're going up like crazy, and it's because there's not enough work upstream. First of all, this is a Herculean effort. Yeah. 69 2 months. This is pretty amazing. And you have a very, by the way, you have a very good style of pulling those questions out. The answers that you did that out, so I appreciate that. And I don't know if I saw these, but two groups, not to add to your plate, but two groups that you might want to consider talking to, if you haven't, are the hospitals and FQHCs.
We talked to the hospital association.
Different.
Okay.
The only reason I say that is because they represent the hospitals.
Okay.
But the understanding of the hospitals, I just had a conversation yesterday actually with an executive at Hello Executive, one of the hospital systems. They don't really have much understanding of public health,
right,
and what it means.
Right.
And I think
just
getting
getting
a
that
sense of their level of understanding of what we do.
Yeah.
And FQHCs also, they have a little more because they're deeper in the community, but
Yeah.
maybe having some kind of a.
No, I think it's a great suggestion. If they'll talk to us, yes.
I did see you have University of Maryland medical system.
Already on board.
Yeah.
Yes.
Sure.
Somebody online?
There's a few people who have raised their hands. Roselle Bright.
Rosalie, yes, hi.
Sorry.
So something that I think is something the work group should consider for recommendations across the board is to check out what they're doing in Norway. They've had a program that's been going on for more than a decade, I think 2, where they've invested pretty heavily in mental health for children. They're pretty assertive about identifying children who are at risk of developing a mental health problem. They don't have to have developed one yet, and they try to avert the child from going down that pipe.
You know, it's great that you brought that point
And
up.
they're counting benefits in averting all kinds of violence, criminality, alcoholism, split up families, economic destitution, etc.
And can I just make a comment? Rosalie, I think that that's a really great point, and I'm glad that you have a reference to Norway. It has been brought up that one of the issues is this connection between behavioral health and IT, because there's no set of variables that we have today that we can say that child in this system where we have variables being collected on them is at risk for suicide ideation, or for we can see the outcomes and we can see people later because there are variables for that, but there are no precursor variables that we can mine at a community level or at an individual level today that we can do that. And I think that it is totally doable based on our academic understanding of mental health and the trajectories of substance use disorder to identify those people in 4th grade.
Well, they're doing it in Norway, and they're not using very sophisticated tech tools. They're using human tools to identify those kids.
Yeah. Yeah, so it's possible, and I think I would really hope that we can do something like that.
Thank you, Rosie.
Yeah.
Is there any other question from, commissioners online?
There was something,
No, not at all. Okay. In the interest of time, we're gonna move on to the next item. Thank you so much. Can we please keep your floor here?
I do want to, this is point of reference, this is introduced to Amelia Cafe Kurtzman, and an enthusiast and a public health professional. I presented this scenario to her, of her and her team, and ultimately the team from Morgan State and others, to take this tasking on. There was never this look of dismay or a doubt that we can actually, that she can actually do this. It may have been internal to her, but to me, I still remember the day in my office where I said, "Can we do this?" And you smiled and said, "Yes, we can do this, and this is going to be exciting." The other thing that I think we need to reiterate for the good of the commission right now is what Lena had said. And I will refer to the CDC Foundation, who has been supporting our efforts. We are trying to really do something very unique here in the state of Maryland. And at the end, we're already halfway there, and look at what's been done, right? I keep, I am a cheerleader deep down inside, but I have to keep reminding us that despite all these things of how we're going to get all these meetings in, and how are we going to take this time, and ultimately, look at what's already been done, right? And if there were skeptics at the beginning, I hope that skepticism is still there, because we don't want to let our guard down. But to a large extent, there is a pathway here, folks, that ultimately is going to make us, the state of Maryland, we are convinced, a better place, despite all the odds against us on this type of undertaking.
Thank you.
So I just want to thank the chair for allowing me to cheerlead.
Absolutely. I actually wanted to make a comment, but I forgot. I just wanted to know, just in reference to what Andrea said about we have to strategize on how we're going to disseminate this information in, pieces, so that it's not overwhelming, not only to the legislators, but to the parents on the page. It reminded me of when we made our visit to Indiana, and they told us that one of their strategies toward the end was having all the site visits to legislators. I think it's something we might have to consider, especially as looking at timeline for 2025. I just don't want us to forget, not just waiting for the final report, but then how do we disseminate, ongoing, and disseminate it to the policymakers before the legislature. All right, please, thank you.
Sure, just future announcements. We have our next meeting in January. Actually, we saw earlier, January 23rd. So please consider attending. Really appreciate the person attendance. I think it'll be a great way to kick off. Oh yes, we'll be at a new location, which is just around the corner from this building. It's still the Prince George's. Yeah, it's still the Prince George's County government, and we certainly very much appreciate Prince George's County and the health department for their hospitality. It's been tremendous so far. And we're excited about the new location for what we hear is even more technologically savvy.
It is, it's a little smaller, but it's also, really good technology.
Excellent. But we hope that means we can have in-person presence. Thank you for all of you for making the attempt to be here in person. Thank you to those of you who can't join in person, but are really making sure to join us online.
Thank you. I just wanted to make a final remark on behalf of the Maryland Commission of Local Chairs. We extend our deepest gratitude to all our commissioners, local members of the public for your willing support and collaboration throughout the year. Despite your many responsibilities and busy schedules, you dedicated your time, your energy, your passion, and expertise into advancing our shared mission for improving health outcomes in your state. As we close this final ID meeting of the year, we honor the sacrifices that you guys do and progress productions together. Your commitment continues to inspire us and reaffirms the importance of this work that we're doing. May the holiday season bring to you and your loved ones joy, peace, and renewal. Thank you all for all that you do, and we look forward to continuing this final work. Thank you. Please stay back if you're in the room for pictures into them.
Thank you.
All right. All right, Mr. Madam. Welcome to the night. Thank you.
Camera off. Gina?
Stand by.
Oh, you have one.